Good afternoon and welcome to the 2017 competition for the Daniel Wagner Prize for Excellence in Operations Research Practice. This prize is sponsored by the Informed section on practice and was established in memory of the late Dr. Wagner. The Wagner's main criterion is innovative analytical methods, typically in the mathematical modeling or the solution methodology. Further, the Wagner explicitly assigns great importance to clear exposition, as observed in the written papers already given to the judges and in today's oral presentations. In addition, the Wagner looks for proven impact rather than focusing on the size of the impact. Today we had in a total of 6 presentations. We will have 2 in this session in the areas of logistics, marketing, criminal justice, and healthcare. You made an excellent decision in coming to these presentations. I can assure you, you will not be disappointed. For those of you who didn't know Dr. Wagner, let me introduce him briefly. He earned his PhD in mathematics from Brown University. Upon graduation, he joined the Naval Operations Evaluation Group at the Pentagon, working on operations research for naval warfare until 1956. After 1 year postdoctoral research at MIT, Dr. Wagner joined Burroughs Research Center, where he directed a group of mathematicians performing analysis for the development of digital computers. In 1963, Dr. Wagner formed a new company, Daniel H. Wagner Associates, Incorporated. During his years as president and principal owner of Daniel H. Wagner Associates, Dr. Wagner brought many high-quality mathematicians into the operations research community. This led to significant advances in the mathematical of naval tactics, especially anti-submarine warfare, detection theory, and search planning. Wagner Associates delivers significant applications to the Navy, Coast Guard, and other clients, many of which applications are still in service today. After retirement from the firm, he founded Dr. Wagner continued his commitment to the field of operations research, serving in various teaching and research positions with the U.S. Naval Postgraduate School and the U.S. Naval Academy. He was an active member of ORSA and then Informs for more than 40 years. The idea for today's prize, the Wagner Prize, began in Dr. Wagner's memorial service, where many of his former colleagues gathered. It is made possible by generous endowments from the firms Metron, Inc., Daniel H. Wagner Associates, Inc., and Applied Mathematics, Inc. I am Patricia Neri. I am serving as the chair of the prize committee, and I am a principal consultant at SAS Institute. I am grateful to the judges for their hard work in this year's competition. The members of the 2017 prize committee are Bill Browning, Alan Butler, Arnie Greenland, Mustafa Kabul, Alexandra Newman, Aurelie Feli, Larry Stone, and Ross Lave. Throughout the day, we had the 6 presentations. Each one is of 30 minutes. We will have 10 minutes for questions. Judges will have priority for questions. If time avails, we will allow questions from the audience. Please do not interrupt the presentations for any reason. You will notice that these presentations are being videotaped, so I ask you to turn off your cell phones now and remain on your seats until the conclusion of the questions period. So please turn off your phones, and let me welcome Dr. Eva Lee from Georgia Tech, who in collaboration with Grady Health Systems and Morehouse School of Medicine work on drug effect-based personalized approach to improve treatment outcome for diabetic patients.
Thank you. So this is a joint work with Grady Hospital, Morehouse School of Medicine, as well as Emory University. So I truly have to thank Dr. Phillips, and he was the one that came to me about 6 years ago, basically he had a very challenging problem that he had to look at. Is basically he has to treat some very severely EU patients that have diabetics type 2. And he has to do dose escalation. And they did dose escalation, but the response was not what they expected. In fact, it was reversed. And so he was wondering, he said, could you come up with an idea, a math model that could tell me exactly how to do dose escalation in these patients? And why are there any urgency to do that? Part of the reason is that these patients suffer very severe form of type 2 diabetics, have a lot of complications. And if they don't get the right drug and the dosage, they will die eventually. So, and these are veterans, and they were not very old. In fact, some of them are very young. So I was really surprised. And Dr. Phillips was really nice. And within 2 weeks, he gave us 40 patients. And that is very dangerous, because that means within 1 week, he's going to come back. Did you get an answer? I said, we can't even figure out exactly what on earth is going on. In fact, you know how long it took us? It took us 6 months to figure out what is happening. Like, the data was so complicated. But the first time, then we actually present him the result. He was so shocked. He said, Eva, but this is not what the book told us. The book said if we do this is what we expected. But your model told us exactly the opposite, and this is what we saw in the patient. And so that was really the beginning. And basically, it's very interesting, because if you look at globally, diabetes is really affecting 422 million people, and really causing over $800 billion per year. And in the United States, 10% of individuals suffer from the disease and causing lots of money. But most importantly, 90% of those adults that have diabetes suffer from type 2 diabetes. And then for individuals like women that during pregnancy, some of them may actually develop diabetes, and these affect 7% of the pregnancy. So these are really important to know, because pregnant women, there exists no drug that is approved to actually provide control of the diabetes in their body. So the treatment itself is either you do diet, you exercise, or you give them anti-diabetic drug or insulin. As I say, the women, there's no approval of those drugs for women that is pregnant, and that means the doctors is prescribing those drugs based on their experience. That is not approved at their own discretion. And a lot of times, it has been a common practice for the last 20 years is that anybody that has diabetes is that they are advised to check their glucose level. Basically, 4 times a day at least is that before breakfast, after breakfast, before lunch, and after lunch. So it's 4 readings that taking the measurements. And so currently, here's how it works. The doctors look at the patient's glucose level, and then they also look at the drug effect, understanding, okay, this is how it works, and trying to prescribe to the patient the type of dosing that they should need. And how does that work? Based on the experience of the doctors. So if your doctors actually know the experience. Now, unfortunately, if you look up the literature, many of the clinical trials have contradicting results. So what is the doctor going to do? Okay, A said this, B said that. Okay, now I'm going to make the judgment and give you the drug. So this may not be perfect. What happens is that you come back the next week, I look at your drug glucose level, and then I make assessment, right? So this is trial and error, and that's the dosing experiment, and we call that the titration period. And usually it could last between 3 weeks to really maybe even several months, okay? So until the doctor actually finds the right information. What we propose, so this is the current approach, and what we propose is using the exact data that is from the patient, because they are already getting the glucose data from the body. We want to be able to use those information and generate the true evidence of that individual. So we go down to the individualized, and that is more cost effective. Part of the reason is if you know what I need, then you're going to give me what I need, right? So that is just simply, even just intuitively, it is a lot more, and it gives the doctor a lot more evidence. So if you add that back in, and that is what we call the evidence-based personalized treatment, right? So you have the evidence from the patient itself, and you add those information into the treatment planning. And now, this is interesting. I have to thank the student. Sheng is part of the team, and he's the only PhD survive in this because we have several PhDs working on it. And it was so hard that it is like out of our thinking. And I understand that. So here's the little drug going into your body. Pharmacokinetics means that how does the body go through the body and through the absorption, and how do you characterize that? So when you first absorb it peak, right, the drug concentration, and then the drug concentration is a function of the dosage. D is the dosage, and C is the concentration of the drug in the blood. So as the drug actually start to have effect on the body. So in this case, that's diabetic drug, and it has effect on the pancreas, and the pancreas receives the drug positively. It emits or releases the insulin. In this case, then what you see here is the effect. The effect is represented by the dose, the concentration of the drug in the blood. And so if you combine them together, you got the dose and you got the effect, right? That is what we want. So it is like very important. Traditionally, everybody that zoom in this problem are the pharmaceutical. This is the $1 million problem for them, because if they know exactly how the body actually responds, then they can make the drug that is right instead of doing trial and error. And especially looking at what are the toxicity that these organs are receiving. So previously, the first time that the PK/PD model was established is in 1910. And that was a really beautiful model where you look at molecules and the hemoglobin and how the dissociation of the curves and how the drug actually react. And then, okay, almost 90 years later, Frey finally used this model and said, well, we cannot find the concentration of the drug in the blood, but we could estimate that using the area under the curve. But even with that, you still need continuous measurement of the concentration of the drug in the body. With that, that means it is not practical. You simply will not be able to get those information. So we thought, okay, as I say, it's not easy work because I think after 1.5 years, time really flies, right? Because we at that time were trying many different things. Even though we were able to tell them initially what they do is not right, but we were not able to come up with the model that could reflect what is going on. So then we decided drug concentration, drug effect may not work because we cannot find the concentration of the drug in the blood. But how about this is better? Drug dose, drug effect. Right? Because if I know exactly how much drug dose that the doctor prescribed me, if I can find that relationship, that is really what we want to go after. So now I highlight the dose effect because you notice that drug dose, drug effect, it is very long, so I condense it, but nonetheless, this is really what we are going after. And basically, in a nutshell, it's a complex mathematics, and this is really very challenging. I think for OR people, we are good in mathematics, but the challenge here is not just the mathematics itself, because there's a lot of biology and physiology that you have to understand how the drug actually go through the model, the body. And so here, basically, this is the baseline of your glucose level. Over time, it becomes worse, right? Because of the disease, then your glucose level could be higher. So you have to control them. And when you actually take the drug, then D is the drug, and then it has different effect. Then you try to estimate what is the effect over time. Okay, this is a large equation, and basically for every single individual, we use the blood glucose level and the prescription of the dose from the doctor and estimate the parameter individually. So it becomes personalized. Now, estimating this relate to nonlinear least square problem, which is a difficult problem to do, but nonetheless, this is personalized. So if we look at a patient, this is the patient, one single patient with the glucose level after breakfast and over a period of 53 days. And so this is the glucose level, and what you are looking at is precisely the trend of the glucose level. So this is the statistical smoothing, that's the moving average trend. So you look at, okay, if the doctor look at this, okay, it looks pretty good, right? Not much change, and you don't want speck and everything. And so this looks good. What we do is we use maybe about 2 to 3 weeks of the initial patient data. So that means the reading that the doctor prescribed the medication and the reading of those glucose level. And we do the prediction. We do the least square and find all the parameters. And then we predict what is going to happen to this patient. And the green line is the prediction. So you notice that it looks pretty good, right? It actually captured the trend. And this is what we would like to be able to put it into the treatment planning model. Okay, so this is the individual patient, what they have. And in the decision, in the treatment, as I mentioned, the individuals come in, the doctors gave them a prescription, they take measurements of the blood, and then they go back to see the doctor, and then they continue this whole process until for pregnant women, they deliver, or until the drug level is steady, and that is the time when you just prescribe that amount of drug. And basically now what we do is we use that as the titration period or the dose experimentation period, use those information, and then basically looking at the trend of the individual. And so the objective itself is to be able to optimize the glycemic control, that means the blood glucose control, over the entire treatment period, and that also minimizing the drug dosage. Now, this is very odd. So the reason why we were being driven by, in addition to like dual objectives, in addition to controlling the glucose, we were controlling the drug dosage. Partly is because the pregnant women really should not take any drugs at all. And so we put that in as a precaution so that they will receive as little as possible. The decision variables will be to determine the type of drugs and the amount of drugs that they have to take every single week. So, for example, if this is week 3 and you have to plan, then you have to plan for a pregnant woman that will be until the delivery arrives. Or if it is just anyone that has diabetes, it will be like for a long period of time. And you personalize the constraint based on the glucose bound that the individuals have. Women and men have different level of glucose, and then morning, afternoon, all of those levels have to be taken care of. And then you personalize the prediction. So this is important. This is the green line that we have, and you include that into the model. And then, of course, there are flexible input. For example, if individuals suffer from other type of complication, then you also include those information. So this is the treatment planning model. So the first 2 terms, this is the positive difference of like the above the upper bound, and this is below the lower bound, and that is the type of drug that is used and how often it's using. And this is like to make sure that all the drugs are being like every single week we give them the drug that they have to take and the dosage. And this one captures precisely the difference of the glucose level, and it has to be within the prediction period. So you basically bound it so that every single optimization, you kind of bound it in a very nice way. So the whole model basically captures all the, like how it moves from one level to the others, and also the morning, breakfast, and all of these bounds. So every single individuals have a specific problem. So this is what we call the personalized treatment planning. And this is really nice because we spend, I don't remember how many weeks we spent teaching the doctors, because for some reason they become really obsessed with it because they really love to learn it. I said, okay, good. You like integer programming? I teach you integer programming. But they chose a really bad one to learn, right? Because this is really complex. So I keep telling, and they forgot about the symbol. But nonetheless, it was really quite beautiful because they seriously learned that this is very useful to them, which I think it's really nice. And of course, Dr. Phillips said, we cannot wait to use it. I said, good, yeah, you are going to. You have to wait because we have to validate the results first, right? Don't go too fast. So then this is like if I have this patient and the blood glucose level blue is the blood glucose level and the target bound is the red one. And this is a patient where this is the orange line is the dosage that is given to the patient, and the green is the eventual glucose level that the patient has. And this is what we prescribe to the patient. And so you notice that we jump rapidly, the green line here, right? So it means that we give the doctor the confidence to be able to prescribe right away the correct level, and it basically stay there. So they actually, if you look at these graphs, and the doctor really loves it because it took them a long time, like almost 3 weeks before they actually get to that level. But look at how fast it takes them. And that's exactly what Dr. Phillips wants. But this is really odd. I didn't tell the doctor what this graph means. The moment he saw these, like when I first gave him some, he said, we are ready to use it. I said, this is interesting. You know exactly what that is. They know it better than we do. In fact, because the moment they see the good solution, they truly know it. And I think it's also interesting if you look at the glucose level, the control. So you see the green line here, it takes longer time for it to get to the level, but the purple line really reach out very fast, right? So I was very lucky is that the doctors really embrace the result. Now, this is the catch. It has better blood glucose level control. It uses fewer drugs. So like I say, our motive is not to reduce costs because doctors, for those of you that, doctors say, if we have to spend more money to treat the patient better, we will do that. Okay? But on the other, in this case, it actually uses a lot less drugs, and that's very nice. So scientifically, I think this model is really nice. As I say, it's very challenging. It has the fluid dynamics model. It has compartmental models to basically model all the molecules and the drugs going through. So it has ordinary differential equation, and you have to set up a nonlinear least square problem, and you have to optimize it, and it is not globally optimal. So I have to say it is not global, okay, but it's a lot better than what the doctors could do, as they say, and they agree. And so this is the first predictive PK/PD model. Very exciting, because this is a 100-year-old problem. The odd thing is that I like to say the doctors are really good, but then at lunchtime, we are always invited by the pharmaceutical people. Like, they come to the hospital, and so we talk about that. The pharmacists, like the pharmaceutical people, are nuts about it. In fact, they love the model so much that they keep asking, when can we have it? Of course, the doctors will not give it to them, right? Because it is they want to use it for their patient. But this is really very nice. For us, I think it is the challenge, is the mathematics being able to overcome it, and I think it took, I don't know how long does it take using? It's about a year, right? It's about fair enough, right? So that's why now it looks, when we look back, it seems really fast, but it takes a long time. And the multiple objective optimization truly is nice, is that it allows us to incorporate this information. You can predict, but if you cannot incorporate, you don't have those information, right? We are able to incorporate that. So that's also very nice. So I think we are very excited. Of course, the doctor likes to say, okay, we never had that, and now everybody is excited to know if it works for other type of disease. But if we look at from the scientific point of view, the multiple objective also allows you to really incorporate many different constraints. For example, it's not just one drug they use. It's multiple drugs. In fact, the veterans use many, many drugs. And how do you actually model that? And the good thing about this model is that you don't have to worry about the compliance. You don't have to worry about the genetics. Why? Because their response factor in exactly the genetics and the compliance. I really don't care if you just take the drug every other day, right? Because your blood glucose tell me exactly what you do. So it captures basically inside, and so that's a really, really nice thing. Computationally, it is really hard to do the parameter estimate. And like I say, it is not global. We are not claiming that it's a global optimal solution in terms of the estimate, but it looks really nice. And the real-time tool, real-time decision tool, is exactly what the doctors want. And that's one of the things that now they like to think about. We talk about analytics, right? Then all of a sudden, the doctors feel that we are the one that can give them the solution. That means everything has to be real time. If it's not real time, something is wrong. But of course, it cannot be real time, right? We have to work very hard to get to there. But I think, here's what I think. This is a dream OR problem. OR here means operations research, not operating room. So why is it a dream? Because this problem is very hard computationally, it's very hard mathematically. And yet, it has lots of practicality, and it is very timely also. It comes at a time when the doctors really demand an answer and a solution from the computational community. So I think it is the right time. And I didn't mention, when Dr. Phillips came to me, Grady and Morehouse also came to me at exactly the same time. Then I like to ask them, I said, did you guys actually talk to each other? And they said, no. They all just have the same problem. They're not like talking to each other, like thinking about that. Like mathematically, we really love the problem, but medical science itself, then I think the advance to them is even more so, is because this is the first PK/PD model that allowed you to really link the drug directly, the drug dosage to the drug effect, and very practical, and it allows you to personalize it, like for individual patients, and which is very important because we are not one size fits all. In terms of drug dosage, there is not such thing called one size fits all. And the good thing is that it is very lean, right? What does it use? Just the blood glucose data every day, which they do all the time for the last 20 years anyway. So I think that is really nice, and being able to put multi-objective here allows the doctors to input some of these key critical structure or key features that has to be incorporated within the model. And doctors always like to say, if you can do A, then they will ask you, can you do B also? And now I learned, in the past I would say maybe, or like now I don't even say maybe, I say, okay, tell me what you want first, right? So I would be prepared. And clinically, I think it's really nice because we were able to test it on the pregnant woman, and Grady basically served about 3,000 pregnant, delivered 3,000 babies per year, and many of them are high-risk patients. And with that, we save about $12 million of the cost. And type 2 diabetics and patients across Grady and VA, and it's about 40 million. But it is more than just money, because newborns, if they were born with the with some of the disease, it is their whole life that is very difficult. So from our point of view, it's like it is their life and that they have quality of life that really makes a huge difference. And also it reduces the practice variance, and it gives the doctor a lot more power to prescribe the right dose without worrying about that they did something wrong to the patient. Also, you can really look at equity of access and also the clinical training. So, of course, less side effect is very important, and being able to improve the patient and patient-doctor relationship, because now you know how I react to the medication and you know how to prescribe that. The added bonus is it uses a lot less money. So I thought of this, and I didn't actually even think about it myself, because as you are absorbed in this problem. So IOM, that's Institute of Medicine, and now it's called National Academy of Medicine, talk about 6 factors of healthcare: safe, effective, efficient, timely, equitable, and patient-centered. And we have every one of them. In fact, I wasn't aware of that until just last week when I was up in DC, and one of the fellow in IOM talked to me, and he said, by the way, this is the only example we can think of. And then they keep trying to come up with something. Well, I said, I don't know if that's the only example, but I'm very happy if there exists an example and it works. So let's say I want to thank the leaderships of Dr. Phillips and from Emory Universities, and Dr. Kwasi from Morehouse, and Grady and Michael. And so I want to share with you the video and of my medical colleagues. Whoops, what am I doing?
Great honor that our work on precision medicine, personalized treatment for diabetes, has been selected as a Wagner finalist. Since 2011, Dr. Lee and I have collaborated on numerous large projects with remarkable success. Advancing ED throughput, reducing medication errors, and reducing surgical site infections are some of the projects we've collaborated on. We believe the operations research and analytic tools utilized by Dr. Lee and her team can transform our healthcare delivery system. At Grady Hospital, only 8% of the patients have private insurance. Any improvement made to patient care are critical. Any dollars saved is savings for the taxpayers of Fulton and DeKalb counties. I personally worked to ensure that Dr. Lee had access to EMR data, the clinics, and inpatient units to effectively analyze relevant data. The implementation of Dr. Lee's predictive dose effect and personalized treatment system in our clinic has made significant impacts. It saves close to $40,000 per at-risk pregnant patient. Grady delivers approximately 3,000 newborns each year, many from at-risk mothers. It's not all about the dollars, though, but over $12 million has been saved in expenses just in pregnancy cases, and over $40 million for other diabetes patients. But most importantly, the newborns have been given a head start on a healthy life. Millions of dollars have been saved during that process. This is a landmark project, the first personalized treatment for diabetes, and has been proven to improve outcomes and decrease costs.
Diabetes affects 422 million people globally, costing over $825 billion per year. Dr. Lee's analytical work offers a major scientific breakthrough in both pharmacology and clinical practice. For the past 100 years, many outstanding scientists attempted to derive mathematical models to correlate drug concentration and patient response. However, none of those models offered a practical approach that can be used in the clinic. Eva's novel math models are very complex, but they work elegantly. Her models can predict accurately how individuals react using inexpensive data from the daily blood glucose meter. This is the first breakthrough in pharmacology. And she took it one step further. She designed personalized treatment for individual patients, another first of its kind in this era of personalized medicine. Since 2013, it has been used at the Grady Memorial Hospital, The implementation is an astonishing improvement in care quality. It shows that advanced mathematics can offer cost-effective care delivery, improving quality and reducing cost. But there is more to EVA's work. It closes the gap in health disparity. Patients receive the best possible care independent of their race. I want to emphasize, a normal delivery costs about $9,500. Patients with diabetes complication in delivery would cost over $46,000 US. Newborns can suffer from multiple lifelong complications that amounts to millions and billions of healthcare costs. Also, globally, diabetes affects 422 million people, costing over $825 billion per year. EVA's work has been used in type 2 diabetes patients at Grady and other hospitals, improving lives of hundreds of thousands of patients.
Oops, sorry. And that's all. And I do want to show my last. Oops. Where's my? Sorry, I guess yeah. That is all, and I want to. Huh? Oh, I guess I rapidly. Sorry, I tend to be doing that, right? Because, but I think I'm done. I went really fast. Sorry about that. But I do want to thank the Wagner judges. You gave me really nice comments, and I really appreciate it, because I think it's a very difficult problem, because I think as I say, we must have gone through 50 students, and that include probably 6 PhDs and 50 undergraduates that are learning all of these things, and it is not an easy problem. And I think Dr. Phillips, I remember when I actually invited him to come to my class and talk to the students that were working on it. And so the students complain they don't get the data, but then when they get the data and the doctor said, well, then we're going to see the results in a week. So you see there's tension, right? And I think it's hard to understand, because you see that little slide of the rest in peace, right? That actually is from CDC, that video. And part of the reason, the urgency, is that people that have diabetes do not die because of diabetes. They die because of the complication, right? They have heart disease, they have stroke, and they have ulcers, and they have things that is extraordinarily difficult to treat. And that's why you see all the ED and stuff, because these patients actually went into the ED. But I think the interesting thing, I really love the problem. Like I say, it is really a dream problem for us, but also it opens up the field OR to get into this area, which is really difficult to get in, because you have to really be very patient with them, but they also have to be so patient with us. But Dr. Kwasi is the person, the last doctor that mentioned, he actually, half of the patients are his. So then I told him, at the beginning, I don't know, and I'm not very good in the video, right? And as they actually do the video, I said, Dr. Kwasi, half of these patients are yours, okay? So either you're going to talk about them or you don't talk about them. But of course, he really loved the work, and he said it is really important. And also, this is the first trial that we have that actually have equal amount of Caucasian and African Americans. So that also makes it really beautiful, because a lot of times when you test things, you don't have your choice of individuals, but you really have to just look at whatever that is given to you and try to test it. So thank you.